4 minutes. That is how long the brain tolerates zero oxygen before permanent damage begins. 6 minutes to cardiac arrest. These are not estimates. They're biological constants that apply to every human being on Earth. And most completely obstructed airways in the civilian environment are caused by a structure that weighs about 2 ounces, that every person listening to the podcast has in their own mouth right now, and that can be cleared in under 10 seconds with a maneuver that requires no equipment at all, the tongue. Today we talk about the airway. I'm Dr. Marco Torres. This is Talking TACMED, episode 9. When civilians think about airway emergencies, they think about the dramatic ones. A choking victim with a piece of steak stuck in their throat, a drowning, an anaphylactic reaction with a swelling tongue. These scenarios are real, but they're not the most common airway emergencies a civilian responder will encounter. The most common is simpler, quieter, and more lethal because it's often missed. It's the unconscious patient whose airway is obstructed by their own tongue because gravity is pulling that tongue backwards into the pharynx, and because the patient is not conscious enough to cough or reposition. These patients often breathe inadequately, sometimes snoring, sometimes silent, for minutes before anyone realizes what is wrong. By then, brain injury may already be in progress. This episode is the Civilian Airway Playbook. We're going to cover what you can actually do without a tube, without advanced equipment, without paramedic training. It's a short list, it's effective, and it will work on a substantial fraction of the airway problems you will ever see. First, let me start off by walking you through the upper airway anatomy, because you cannot fix what you do not understand. Air enters through the nose or mouth. It passes through the pharynx at the back of the throat, through the larynx, through the trachea, and down into the lungs. The structures most vulnerable to obstruction in the unconscious patient are all in the pharynx. The tongue is attached to the mandible, the lower jaw. And when the muscles supporting the jaw relax, as they do in unconsciousness, the tongue falls backward under gravity and can completely block the pharynx. The epiglottis, which is a small flap of cartilage that normally redirects food away from the airway, can also obstruct in severe sedation or deep unconsciousness. Why position matters? When an unconscious patient is lying on their back, gravity pulls the tongue directly backwards towards the rear wall of the pharynx. When that same patient is positioned on their side, gravity pulls the tongue laterally away from the airway and the airway opens. This is the physiological basis for the recovery position, and it is the single most important airway intervention available to civilians. So let's talk about partial versus complete obstruction. A partially obstructed airway makes noise, snoring, gurgling, stridor, a high-pitched wheeze. A completely obstructed airway is silent. Now, this is counterintuitive, and it matters. The patient making loud airway noises is, in fact, moving some air. The patient making no noise and showing no chest rise is moving none. Silence in an unconscious patient is the worst sound. Now, with that anatomy in hand, the interventions become clear, and they're almost all about position and jaw position. The National EMS Model Guidelines and CATI recommended doctrine converge on the same civilian airway sequence. The sequence is deliberately narrow. It includes only interventions that a non-medical responder can perform safely without training intensive equipment and without the risk of making the problem worse. There are 4. Let's talk about the first one. Head tilt chin lift. For an unconscious patient without suspected neck injury, you place one hand on the forehead, the other under the bony part of the chin, and you tilt the head back while lifting the chin forward. This repositions the mandible anteriorly, which pulls the tongue off the rear pharyngeal wall. You're going to want to listen for breathing and watch the chest. If the maneuver works, the patient will usually resume adequate breathing within just a few short seconds. Number 2, the jaw thrust. For an unconscious patient with a suspected neck injury, with basically anyone who has fallen from height or been in a significant vehicle collision or sustained a blow to the head or neck, you do not tilt the head. You place your fingers behind the angles of the mandible on both sides, and you lift the jaw forward toward the ceiling without moving the cervical spine. This achieves the same airway opening effect as a head tilt with zero neck movement. Any civilian who has watched 5 minutes of instruction can perform it. Number 3, the recovery position. For any unconscious patient who is breathing adequately and has no suspected neck injury, placing them on their side allows gravity to keep the tongue out of the airway without requiring you to maintain a manual maneuver. This frees your hand to do other work. It also reduces aspiration risk because if a patient vomits, the vomit drains out instead of pulling on the throat. Number 4, finger sweep for a visible obstruction only. If and only if you can see a solid object in the mouth, a piece of food, a loose tooth, a foreign body, you can use one finger to hook it out. You don't blindly sweep a mouth where you cannot see anything. Blind finger sweeps can push obstructions deeper and can trigger vomiting in patients who were on the edge of consciousness. 4 interventions, all achievable with zero equipment, all taught in any competent basic life support course, all underused by civilians because the training emphasizes compressions and defibrillation and treats airway as an afterthought. All right, so let's discuss a specific scene. Family backyard gathering. Uncle is in his late 60s. He's got a known history of cardiovascular issues. He has been sitting in a lawn chair. You look over and you notice he has slumped sideways. You walk over. He is unconscious but breathing, though the breathing sounds labored with a loud snoring quality you have never heard from him before. No visible injury, no obvious mechanism. This is likely a syncopal or cardiac event, not trauma. No suspected neck injury. So here's the response. 0 to 30 seconds. You recognize the snoring as an airway obstruction. His tongue has fallen backwards, so you help him on the ground, flat on his back, because you cannot work the airway effectively in a lawn chair. You call out for someone to dial 911, naming the caller specifically. 30 seconds to 1 minute. Because there is no suspected neck injury, you perform a head tilt chin lift. Within seconds, the snoring stops. His breathing becomes quieter, more regular. The tongue has moved off the rear pharyngeal wall. You check the pulse at his neck. Present, regular. You check chest rise. Present, adequate. 1 to 2 minutes. You roll him into the recovery position. The airway stays open through gravity alone. Your hands are now free to check him again, to talk to 911, or to direct bystanders. 2 minutes to EMS arrival. You stay with him. You monitor breathing. You note anything that changes. If he becomes unresponsive to stimulation, if his breathing becomes irregular, if his color changes, you have likely bought him the time he needs for the paramedic to arrive and make the definitive assessment. You haven't done anything fancy. You have positioned him correctly. That may be the only thing that mattered. Now, flip the scenario. Same uncle, but this time he fell off a ladder earlier in the day and has been complaining of neck pain. Unconscious, snoring, respiration. What changes? You do not tilt the head. You perform a jaw thrust. You hold the airway open manually until EMS arrives without moving the neck. You do not place him in the recovery position because rolling a patient with a suspected C-spine injury without proper log roll technique can cause harm. Same problem, different mechanism, different intervention. That's the civilian airway doctrine. So, what are the 3 takeaways from this episode? 1, the brain tolerates 4 minutes without oxygen. The most common cause of upper airway obstruction in the civilian environment is the tongue falling backwards in an unconscious patient. Almost every other airway problem is a variant of or layered on top of this single mechanism. 2, the civilian airway toolkit is 4 interventions: head tilt chin lift, jaw thrust for suspected neck injury, recovery position for stable breathing patients, and a finger sweep for visible obstruction only. All zero equipment, all teachable in minutes, all underused. 3, the deciding question is always mechanism of injury. If neck injury is possible, you use the jaw thrust and you do not move the neck. If neck injury is not possible, head tilt and recovery position around the table. Mechanism drives technique every time. I built a laminated 1-page airway quick reference PDF that shows all 4 interventions, the decision point between them, and the specific scenes where each applies. It's designed to live in your IFAC or on a refrigerator, anywhere you want to put it. It's free. The link below in the show notes. Go get it. Go download it. Next episode, we zoom out to environmental trauma, specifically heat, because heat casualties are trauma casualties, and the physiology of what heat does to the body is less well understood by civilians than almost any other category of emergency recovery on the show. So I'll see you there. I'm Dr. Marco Torres. This has been Talking TACMED. Stay ready.